Hi, everybody. It's Dr. Tom Moorcroft here. I'm joined by my good friend, Dr. Neil Nathan. This is just such an awesome opportunity for me. I'm so excited and feel privileged to be talking with you, Neil. For those of you who may not know Dr. Nathan, he's sort of one of the gurus of integrative medicine, and he's written books on mold and mycotoxins. Also, his newest book is a bestseller, and its name is Toxic: How to Heal Your Body. And, you know, the thing I think that's so important to talk about today, Neil, is that, you know, we all see these patients with chronic tick-borne illnesses and Lyme disease, you know, mold toxicity. And sometimes it's a struggle to help them get better. And I just thought that it's Lyme Disease Awareness Month. And so I want a lot of people to learn about acute Lyme, but I also want them to learn that there's hope if they've been sick for a really long time. And whenever we talk and whenever I see you lecture, I see the message of hope through a clear scientific approach to their treatment. So I thought it'd be great to have a conversation with everybody and, you know, see if you could share some knowledge with us and answer some of their questions.
I'm happy to do so, Tom, anytime.
So, I mean, you know, I guess it was like last year we were talking at a conference in Maryland, I think, and we both were sort of, you know, talking about the nervous system and how that all plays a role. And I was just kind of like thinking back, I was wondering, like, I kind of have looked and figured out how my nervous system got into treating people with these different, you know, chronic illnesses. And I was sort of wondering, you know, what sort of got you started in this field before we dive into kind of some of the approaches you take.
Okay, how much time do you have, Tom? Anyway,
well, there used to be those things called Cliff Notes, right?
Okay, no. I got started in this field because trained in conventional medicine, I had a burning passion to help everyone who walked into my office. Mm-hmm. You might think that that's a delusional concept, but here I am 47 years later, still delusional, still looking to do that. And I realize that I can't always do that, but that's still my goal. And I realized early on that the tools that were given to me in conventional medicine would take me so far, but I needed more tools in my tool bag. I needed to understand more. Mm-hmm. So very early on, and we're talking the early 70s right now, I studied acupuncture, homeopathy, osteopathic manipulation, and that continued, so that what I found is that each subject that I studied gave me tools to help some people that I wasn't able to help with the tools that were originally placed in my tool bag. Right. And so that just escalated. I'm simply curious and interested. So I began to draw to me a population of patients that wasn't being helped by conventional medicine. And as I continued my educational learning process, I was able to help more and more of them. Mm-hmm. And so that made me want to study even more so that I could help more of them. And that's been a spiral throughout my life. So back in the mid-'80s, I was running a pain clinic for a regional hospital, and we began to see a strange critter that was called fibrositis, now called fibromyalgia and chronic fatigue syndrome. Right. And nobody quite knew what we were looking at. We didn't have much of a handle on it. And originally people thought it must be a psychological illness because there are so many symptoms that this has got to be in people's heads. Mm-hmm. But it became very readily apparent to me that psychological interventions, including medications, made very little difference for these patients. Right. So it wasn't that, it was something else. And we slowly acquired a body of knowledge in a field that is now called functional medicine, mm-hmm. where we began to understand that these patients had a multi-system complex illness, which involved adrenal, thyroid, endocrine disorders, the deficiencies, particularly of magnesium and other nutrients, food allergy, intestinal dysbiosis. And we added to that over time dental issues, mold toxicity, Lyme disease, co-infections, and this became a field that we now work in that we call treating complex medical illness.
Mm-hmm.
And I got involved in this field early so that I have a fair amount of experience, literally thousands of people that have what looks like chronic fatigue, fibromyalgia. These are the names that get put on it, but the causes are usually Lyme, mold, co-infections, chronic viral infections, which also have these other imbalances that we notice. And that's kind of how I got started.
Well, it's awesome because I share the same delusion.
I know you do.
Yeah, I mean, it is. It's like you want to help these people who are suffering, and I feel like it's like you're on the forefront of that from the very beginning. But I mean, so with all the sort of the fibromyalgia and stuff, I mean, from sort of like, the 80s through now, I mean, are there any kind of big sort of mental frameworks or paradigms that you feel have really made a huge difference in the way you're approaching patients like this?
Sure. First of all, there are a lot of them. It's not just one. We are constantly learning new things that give us another piece of the puzzle that really helps us to do better with what we're doing. So from a causative point of view, we are finding that Lyme disease and co-infections and mold toxicity are the primary drivers of the illness for most of the patients we see. Both of those trigger mast cell activation, which is one of our newest fields of understanding that has enabled us to make more progress. Mm-hmm. And also, Lyme and mold affect the brain and the nervous system in ways that we're beginning to understand now that I think will make a huge difference in helping these people who have been particularly stuck, not being able to move forward, those patients who've become unusually sensitive to virtually everything. It's in understanding what's happening to the brain that we often need to begin treatment, even if they have Lyme or mold. If you start with that, they're often too reactive to be able to give them the things they need to get well.
Yeah, and I mean, this is one of the things, especially in the beginning of my career, that I found really challenging was I would do what you're supposed to do, and everybody came in and they thought they had Lyme, I thought they had Lyme, and they did. But then I started treating them, and then there was like this nuclear explosion because I just went gung-ho. And then, and certainly I think both of us have talked a lot about things like the role of the vagus nerve in this and the role of the gut and the brain. And what's your understanding of that at the moment?
Well, the two biggest pieces of that, which you're alluding to here, is the vagus nerve and the cranial nerves that are connected to it, and the limbic system. Mm-hmm. And although these are two different separate areas of the brain, they do communicate with each other very, very closely, and each affects the other. So if the limbic system is being messed with, that will affect the vagus nerve and vice versa.
Right.
So for listeners, the limbic system is the part of the brain that deals with emotion, mood, sensitivities, meaning sensitivity to light, sound, chemicals, touch, mm-hmm. EMF. It also, to some extent, deals with cognition, meaning brain fog, focus, memory, and concentration, and energy. And if we look back, virtually all of our patients have components of that to their illness.
Right.
So what I've learned is that many of these patients can't make progress unless they literally reboot their limbic system by really doing treatments specific for it. Now, these are amazingly amplified by also working on quieting down the vagus nerve. Mm-hmm. And for listeners, what we've learned recently is that the key component of the vagus nerve is that it monitors the body for safety. And if the body doesn't feel safe, it attempts to protect it by becoming hypervigilant and hyperreactive. So many of our patients who are the most affected have a vagal nerve component and limbic component, which I'm understanding needs to be addressed sooner and sooner in the clinical course if you're going to make progress and not get stuck.
Yeah, I mean, I've noticed the same thing, and I remember I was reading a study, and because part of this limbic system, the part that has to do with memory and memory creation and retrieval, also interacts very directionally back and forth between that and the prefrontal cortex, which is the part of the brain that helps us sort of have our social mores and stuff. But what's interesting, and so we get the brain fog, and we get all this sort of mood and anxiety and hypersensitivity kind of in the same patients. But I remember a study, because when I look at the PET scans and SPECT scans of all these fancy metabolism scans in the brain, we see that the areas of the limbic system and that temporal lobe and then the prefrontal and some parts in the middle get all affected. And the thing I remember is I saw a study once where they did functional MRI, fancy scan for people listening, a fancy scan on your brain, basically, of how the brain works. When we had 3 people were playing catch, but they did it on a computer. It was like an early video game. And the 3 people were tossing the ball back and forth. And then the researchers asked 2 of them to exclude the third person. And then they scanned them all. And the third person had areas of their brain light up that's analogous with some of these places that we're finding our patients have problems with. But when you go back and look at the study, the one person with the changes was a real person. The other 2 were just computer pretending. So if you think somebody disses you, this can happen to you.
Well, I don't even want to be dissed by a computer.
I know. But it's so important that our experience of our environment is a real piece of who we are.
Right. And I'm going to add the component of this happens on a cellular level as well. Dr. Bob Navio's cell danger response model, which he's recently expanded, teaches us that there is an actual biochemical cellular memory of when events have happened to us that predispose us for having a recurrence of whatever it is that bothered us as soon as the cells have any inkling that, we experienced this before.
Mm-hmm. That sensitivity piece you talk about, I think is a thing that I see. And I'm always trying with my patients, one, to figure out, are they having a Herxheimer, or are they hypersensitive? Are they potentiated to this? Or is it, or is it this sort of Herxheimer reaction, or is it this other thing? And I mean, that's a critical piece, because I mean, in our treatments, clinical is so important. So how are you differentiating between those 2 states? I mean, since they're so common that our patients go through both.
Correct. And as you're also pointing out, it can be quite tricky to tease this apart and figure out if a patient has a reaction. Is this a Herx? Is this another release of toxin from another mechanism? Mm-hmm. Is it that they're having a bad day and they've been exposed to mold or EMF and it's setting off their system? Is it a mast cell activation piece? So I can give you, or all of the above, which happens. I can give you hints about that. So the mast cell activation piece, which we've recently become aware of, is very important. The tip-off to that is when a patient has a reaction to any substance. It's not an allergy. Looks like an allergy, but it's not. If they have a reaction to any substance that they eat or drink within minutes of swallowing that, and that reaction would be something in the category of a histamine release, producing symptoms like flushing, palpitations, itching, rash, hives, abdominal pain, diarrhea, literally within minutes of anything. So that if a patient tells us, I ate that and I immediately had this reaction, that's not an allergy. That's a histamine release. Mm-hmm. That's mast cell activation. And that tells us that that's a piece we need to be working on. If a patient goes on a new antibiotic, for example, they're being treated for Lyme or any other infection, and they immediately, within a day or two, they have an intense exacerbation of their usual symptoms, that's a herx.
Right.
If that reaction goes on for a much longer period of time, that can actually be porphyria, which many people don't think about.
Right.
But if it goes on more than a few days, we need to be thinking not so much herx. What else is going on that we need to be addressing? Go ahead, Tom.
I was just going to say I really want you to dive into that because it's super important, because I remember I had a herx for 4 months.
Right.
And I was told by doctors I trained with, you could have a herx for 6 months. I'm like, that doesn't even make sense based on the pathophysiology, what we think is actually happening.
Right. You can't.
Right.
So, for example, if you had mold toxicity and you had taken much too much binder of any kind, charcoal, clay, chlorella, cholestyramine, don't care which, if you're taking too much, it can mobilize toxin faster than you can process it, and it will lead to an increased level of toxin in your body, and you will get a prolonged reaction. That can go on for months, because if you keep doing it, you just keep generating more toxin in your body, and that expresses the need, you got to stop it, let that settle down, and try much, much smaller doses that are much more comfortable for that individual.
Well, sorry, I love to interject because I'm thinking of little things that you've taught me over the years. And I remember a conversation like this, last year, and I just consulted with somebody. They do charcoal 3 times a day. They can't handle it. They're falling apart and they're hospitalized. And, we went through their urine for mycotoxins, and, I thought that they could benefit with some cholestyramine, and then their psychiatrist was actually willing to prescribe it if I gave them some literature. And I said, start on 1/8 of a teaspoon every other day. And she's like, within days, she's like, not only am I tolerating it, but I'm starting to feel better. But when you put higher doses, she felt worse, like you're saying.
Right. It's really very common, much more common than people realize.
Right.
And for those of us who work in this field, I have this aphorism, which is, if some is good, more is not necessarily better. And I can't tell you how often I have to say that to patients, because we live in a world in which we're taught that if some is good, more is better.
Yeah, right.
We're type A people. We're proactive. Well, I've got to do more because then I'll get better faster. And unfortunately, the body doesn't have that wisdom. The body, anybody's body, has a very, very clear idea of what it needs and what it doesn't need, and it tells us by its symptoms. Yeah. And we can ignore that at our own peril, or we can listen and really help people by following that along.
It's interesting because I do think we want to get better faster, and more is better and all this stuff, but I find myself thinking, as you talk about that, the more toxins we pull at a rapid rate, it's like I always use this term, like the Martians are invading, and I think I'm getting old enough now that the younger people don't even know what I'm talking about. But it's like the body is just like experiences this rapid changes and this inflammation from those toxins as it's under attack. And in these hypersensitive patients, I think it escalates them even further than they would have been otherwise, just because they feel like they're under attack.
They are. But
right. Yeah.
They're being attacked by a toxin, which is in too high a dose for their body. And recognizing that allows us to work with it, and not recognizing it is a recipe for going down the rabbit hole and going nowhere fast. In fact, you can get really, really sick if you're not listening.
Absolutely. We have a couple questions that have popped up, and I'll interject one now because Scott sent a couple of them to us, which is cool.
Okay.
And I figure it'll so we can weave these into the conversation, because for mycotoxins, Scott is asking if we could talk about interpreting urinary mycotoxin testing after an initial test was elevated, and a subsequent test showed increased elevation or increased toxin levels, maybe suggesting it could be a good sign of improved detoxification. At what point would you suspect that ongoing elevation of the urinary mycotoxins is pointing to something other than maybe improvement,
Right. Very good question with many answers to it. So first of all, I find the urine mycotoxin testing the most useful test to define which toxins are causing my patient's symptoms and giving us a blueprint for treating it. Now, one of the things that we see a lot, and by a lot, I mean, I would estimate in 80% of my patients, is that when we get our first test, it shows the presence of various toxins in various amounts.
Mm-hmm.
If we treat them and they start to get better, 80% of them will have higher toxins the next time out. And I prepare my patients for that. I tell them that this is going to happen. Do not freak out when you get higher numbers. The reason for it, and it underlies what we're talking about, is that mold toxin interferes with the body's ability to detoxify. Literally, it's a poison, so that it poisons the systems that we need to process it, the kidneys, the lymphatics, the gut, the liver, so that as people improve, they can actually mobilize the toxin that always was there that we didn't really pick up on the first test. So as they get better, very, very common to see higher numbers.
Mm-hmm.
Now, as Scott is also pointing out, there are other reasons we see higher numbers. And the way to tease it apart is if a patient comes back and says, I'm doing everything you asked me to do and I feel better, but my numbers are higher, I'm looking at improved detoxification.
Absolutely.
But if the same patient comes back and says, and I feel worse, then we're thinking I'm overdoing my binders, I'm overdoing my antifungals. We're killing or mobilizing the toxin faster than they can handle it. Not a good thing, gotta cut it out.
Mm-hmm.
Or they're still being exposed to mold in some environment that they haven't figured out, and their higher numbers and feeling worse is due to the fact that they still have mold exposure and they haven't moved into a mold-free environment, which is critical for healing.
Right. And that's mold-free environment's kind of hard, especially, over here in New England. Certainly I find some people who just don't have the ability to move in the moment and they can remediate the big stuff. Are there other tricks that you're finding are effective in your practice? If somebody, realistically, the answer is get out of the mold. But there's a reality for some people that might take them a little longer than I can do it in the next 4 weeks. So what do you recommend in terms of at home?
Well, first of all, if you give binders as treatment,
mm-hmm.
you will help or at least stabilize most of these patients. Now, it's a stopgap. You can still live in your moldy home, but you've got to be working at figuring out how to get out of there or remediating it. You cannot get well if you're staying in that moldy environment. So we can stabilize them. We can help them. A few people will even improve, but they won't get well staying in that environment. So again, it comes back to us to do our best to help them function at as high a level as they can, given the fact that there are many reasons, social, financial, and other, where you can't just immediately leave your home. It's just not feasible.
Exactly. Do you find things like air purifiers, either, fancy HEPA ones or the photocatalytics are helpful? Or because I know a lot of people come in talking about that, and I have my own opinions, but.
Well, I think we have some research and data on it. A HEPA filter is good for reducing the amount of mold that you're exposed to, but it won't remove it completely. So is it helpful? Yes. Should you have it at least in your bedroom? Yes. And maybe in other rooms of your home. The new molecule filter looks like it is able to help remove some of the mycotoxins a little better than some of the other machines have. So yes, having that is helpful, but it's still not going to completely put you in an environment that is safe for you and your family.
Right. And that's the thing. I mean, I see a lot of people where one person is sick and the others aren't sick yet, at least to the, or when we start talking about it, they're like, oh, I wonder, because I've been having they come in with their child, but then two or three other people in the family have these sort of smoldering symptoms that they wonder about.
Right.
And one of the other things I think is important too, to just point out in terms of exposure, is it doesn't always have to be at home. I have many children who have problems at school, and the schools are infamous for not wanting to admit that there's a problem at the school. And we have children who have to stay home because they can't tolerate the school, when all they want to do is go be with their friends and learn at school. And the school tells them there's school avoidance behavior, when really it turns out that there's mold. And, oh, by the way, there's a leak that happens every time it rains, and there's a puddle in period 4 classroom or something,
No, schools are notoriously moldy. They're often low budgeted. They can't repair the leaks as fast as they come. And over the years, they're often a major problem for children. So is a work environment. Many people are in a work environment that's toxic to them. Your car can be a toxic environment. So yes, you're absolutely right. It's not about just home, but anywhere. For some people, it's when they go to their parents' home, which is 50 years old and never repaired, and they can smell it, and the parents go, well, I'm okay here, and I'm sorry I'm sorry you feel that way. Are you saying you never want to visit me again? And then we get into so, I mean, I recently got an email today, in fact, from one of my patients who's done very well, who went to stay with her parents for a weekend, could smell mold, but felt compelled to have the social visit, and then had a severe exacerbation of her symptoms. And she's getting upset about, okay, now my anxiety is coming back and my head is bursting, and what do I do?
Right. Well, I mean, I guess that is the question, is what do you do? I mean, so in your experience, why are people that sensitive? Like, why can't a person, if they've been treated, then go out or I'm assuming this person's treated, go out and be exposed to mold again? Or maybe another way to put it is there a period of time after they feel well that then they would be able to experience a mold exposure and not get acutely sick?
Well, that's a complicated question, because our patients' biochemistry and genetics is so unique and individual that the answer is many of my patients, when they get well, can experience a moldy environment briefly and not get sick in it.
Right.
Others who are more sensitive, we talked about this cellular memory, can be exposed and get sick very, very quickly, even though they were doing quite well. So first of all, it's an individual process. Right. And it depends on how far out from treatment they are. If they've just barely quieted down their nervous system, they're more likely to be reactive. If they've been well for a couple of years, then they're much more likely to tolerate that environment adequately.
And what about the genetic piece? I mean, we hear so much about mold and the genetics, and I don't know. I can't say that I've ever tested anybody in my practice where they haven't had, sort of the HLA genes that everyone talks about. But again, I mean, if it's a quarter of the population and I see really sick people who are super sensitive and have mold, it's a biased look from my perspective. But what's your feeling on genetics?
Well, I don't find the genetic testing helpful. And in fact, sometimes it's harmful, because it gives a patient the sense that, I'm genetically screwed. How can I possibly function in this moldy world given my genes? And the reason I don't find that helpful is I don't think that's true. I have not found any genetic picture influence treatment one bit. Meaning the patients who supposedly have the most awful genes often do extremely well with treatment. And some of my patients who have no genetic predisposition, supposedly, are struggling. So I don't personally have value in doing that testing. I know that there are other physicians who find it valuable. I don't, because it doesn't help delineate for me anything that I'm going to do clinically to get that patient well, and it doesn't compromise their healing one bit.
It's refreshing to hear you say that, because I certainly have found the same thing clinically and stopped using it for the most part a long time ago. Because it's like, what is going to be helpful? So it sounds like what we need to do is get the urine for mold toxin testing, and then, treat the patient that's in front of us with all the other things. I mean, certainly you mentioned the mold people aren't just mold people. They might have Lyme or Bartonella or porphyria and that kind of stuff. So, Scott, there's a couple questions, and Scott just threw one out about testing that might emerge from Dr. Novell's work on the cell danger response. And so maybe we can remember to talk about that, because one of the things that you talked about is that everybody's an individual, and some of this genetic testing is actually potentially more harmful, because I have everybody come in and say they had the dreaded one. And now I've actually seen the dreaded HLA pattern be labeled to almost every single one in the Rosetta Stone. So I don't know who is interpreting these anymore, but I feel like, it's kind of like a CD57. If it goes down, but you feel better. And if it goes up and you feel worse, now it's worse. So what are you doing in practice to help people with sort of that mental, emotional piece, and sort of cell, maybe we can talk a little bit about, how we work with the vagus nerve and cell danger response, and open up a 6-year-long discussion of because it's a big Pandora's box.
Right. How much time do you have?
But it's critical. My patients don't get better unless they address this piece. And so I think that's the most important part of it.
So I'm going to answer that question in a couple of parts. And I'm going to be a little bit self-serving to suggest to those who haven't done so, please read my new book, Toxic: Heal Your Body from Mold Toxicity, Lyme Disease, Multiple Chemical Sensitivity, and Other Environmental Exposures. Because we really do go into detail in this, and I'm told by many of the people who've read it that it really has helped them put it in perspective and to help them understand how to proceed. So now for your question. First of all, I urge people to find the underlying primary cause of illness. That is usually mold or Lyme or something in the Lyme realm. So many people in functional medicine have learned how to do a whole lot of testing, which includes testing for, amino acids, methylation, viruses. All of those will be affected by mold and Lyme. And if you treat those things and don't get at the cause, you're not going to take your patient to healing. You've got to find the cause. And it seems to me like such a simple concept, but I see so many physicians who forget to look for the primary cause, or more important, don't look for Lyme and mold, because that's where they're going to find it if they start looking for it.
Right.
So number one, in terms of when I'm working with somebody, what's causing it? That begs a very important secondary question is my patient ready to be treated for Lyme or mold because of what it has triggered in them? And I'm going to come back to things we started talking about, affecting the limbic system, affecting the vagus nerve, and affecting mast cell activation. If those things are operative and is making a patient unusually reactive or sensitive, they will not be able to take the things you want to give them to cure the primary thing unless they get addressed and quieted. So with most of my patients, my starting point is working on the limbic system, working on the vagus nerve, and then working on mast cell activation, and then addressing the next piece. And again, as you're pointing out, in many, many of my patients, they have mold and Lyme and Bartonella, and it's not an either or. It's an inflammatory soup that needs to be teased apart and worked on.
Well, one of the things you mentioned way in the beginning is your osteopathic training, and I talk a lot. I love your use of the word primary problem, and because it's like, for me, I understand the body can heal itself, but it's stuck. And whether we look at it as being stuck from cell danger response perspective or from polyvagal theory, the body's stuck somewhere. And if I find out what the primary problem is, then they can get better. But if Lyme is number 3 and mold is number 5 and something else is number 1 and all I treat is Lyme and mold, they're just going to flare and not get well.
Right, right. And what you're perfectly pointing out is that people can get structurally as well. And it isn't a stuck place. As a general rule, the body is a unity of mind, body, and spirit. So that if you're stuck in one place, you're going to be stuck in multiple places. And the more of them you can discern or tease apart, the more likely you are to help that patient be unstuck. So I do find, even though I'm an MD, I am blessed to have had osteopaths take pity on me and teach me a great deal. So I've actually been doing osteopathic work for 40 years now. And again, although
20 years longer than me, it's crazy.
Well, although I went to the wrong medical school, I was able to rectify that. Let's put it that way. But my osteopathic training gives me a very specific perception of that stuckness that encompasses not only the biochemistry, which we've been talking about, but the energetic stuckness, the physical structural stuckness, and is a very, very good starting point for many people, where that can begin the process of freeing up certain tissues to allow movement to occur so that healing can begin to occur.
It's so critical. And it's like, you think about like the vagus nerve, and for folks who are listening who aren't sure where that is, I mean, it's coming out of the brain, but it's also coming out right on the back of our neck, right where so many of us are holding all this tension, and we've got the shoulders up and the head forward posture, and we're holding over, and that just really closes us down. But then it also prevents the nerve from functioning properly. And one of the at that lecture we were both teaching at last year, we both talked about polyvagal theory that Stephen Porges has worked on, and it's so interesting because in our work in medical school and stuff, they teach us about the autonomic nervous system, the sympathetic fight or flight part of it, that regulates how we're able to run away from a saber-toothed tiger or turn and fight them. And then the other side being the rest and healing and rejuvenation, as if that's the only parts. And then the other part is, but what happens if I can't run away anymore and the saber-toothed tiger grabs me in his mouth? The only thing I have left to do is freeze and play dead. And that hopeless, frozen state with the depressed immune function and withdrawal from socializing, I see in so many of my patients. And I'm assuming you're seeing the same. So I guess sort of my question is, what's been your experience with that, and how do you get people out of that state if it's so critical for their healing?
Well, it is critical. Again, as Porges points out, and as I know you know, the key component here is the body's perception of safety. And our patients don't feel safe.
No.
They often feel like their bodies have betrayed them and don't know how to proceed, don't trust their perceptions, and they don't trust much of the medical field, many of whom have dismissed their symptoms or not made the right diagnosis or not helped them or told them it's all in their head. So they have, if you will, medical PTSD on top of what is already a nasty situation. Yeah. So all of this is really about, in whatever form you get it, helping the body to restore its perception of safety. Now, most specifically, I'll outline some quick answers for you. To heal the vagus nerve and to heal this perception, there are some exercises that patients can do. I'm very fond of the ones that are in a book by Stanley Rosenberg called Accessing the Healing Power of the Vagus Nerve. At the back of that book, there's 5 or 6 very simple exercises that you can do that is intended to be done with cranial work as well. So right. Combining those two is superb. frequency-specific microcurrent is capable of quieting the vagus nerve with some very specific frequencies that it can treat. A new device called BrainTap, which kind of looks like a virtual reality headset with earplugs, has some wonderful, very simple programs that patients can use that use light and sound to reboot that part of their nervous system. Another thing that many patients have learned along the way is something called emotional freedom technique, where you can have tapping of specific acupressure points on the face and shoulders, which it turns out can shut off some of the stimuli of the facial and trigeminal nerve, which are directly connected to the vagus nerve, and quiet down that neurological event. So I usually try to combine some of these particular modalities depending on which are available to the patient and wherever they live. And then I'm very, very fond of limbic retraining, the program put together by Annie Hopper in her DNRS program. And there's another program similar called amygdala retraining by Ashok Gupta. So combining these is often the starting point for many of my most sensitive patients.
Cool. And for everybody, I'm putting a couple of those in the comment section, a couple of links to them, so that you'll be able to get to them. And anybody who sticks around towards the end, I'll give you a link to getting, I have a little gift for everybody where we'll talk a little bit about how to do some of those accessing the healing power of the vagus nerve exercises. The other thing is I recently came across this cool article where they were finding in patients with Lyme that they had changes in their cardiac, in their heart vagus tone, which is the kind of that part of the vagus nerve that allows you to get into that rest and rejuvenation, healing, going out and socializing more part. And they found that, in patients with Lyme, there was a disconnect between the cardiac regulation and the respiratory rate working with it. So I actually do have people do a lot of work with heart rate variability training as well, and heart-centered breathing to help them get over that piece too. Have you seen that in your folks, or have you used any of that?
I haven't done much of it. Some of my colleagues do, but I have studied it, and I know it to be an excellent approach.
Cool. I'm just trying to get a couple of these. It's hard to talk and get these things in the comments for everybody. I think they're such valuable things. We should get those out. So let's see. I want to make sure we also hit some questions too, because there's a question about what's the best way to, well, actually, I want to follow up on Scott's question is, are there any specific tests coming out on cell danger response to help you figure out what phase somebody might be in? Or how can you tease out, because like you're saying, start with the limbic system and start with the vagus, but are there certain patients where we want to start somewhere else? Or how would you tease that out, like, or where they're at so you can have them create the proper roadmap for their success?
Right now, in space and time, I think the best tool we have is taking a good history and really listening to our patient. And as we've talked about, you can listen not only to their words, but if you have manual skills, you can put your hands on their body and you can listen to what the body is telling you in that way as well. For most physicians, it's, if you listen carefully to what people are telling you, I think you can get a pretty good idea of where they are in space and time. That's where we are right now. What Scott is referring to is there's a number of tests that Dr. Navio is working on currently that may help us be a lot more precise about where they are in their cell danger response in the future.
Right.
What I can say is he's working right now on a test which is primarily measuring sphingolipids, which may give us some more immediate information, and it may be commercially available within the next year.
Wow.
For the extensive testing that Dr. Navio does, in which he measures over 600 metabolites in one specimen of blood all at the same
Oh,
time, and really gets a handle on the metabolome to really understand these complex interactions. That's in the works, but we're probably at least a few years off from it.
Right. Do you see that down the road with that? There's going to be changes in how you would clinically address the patient based upon those results?
Well, Dr. Navio has already done the metabolomic profile for a variety of some of our chronic illnesses. I mean, I am honored to have co-authored a paper with him on chronic fatigue in which we looked at that. But he's also done that on Gulf War syndrome, traumatic brain injury, autism. He's looking at doing a study right now on multiple chemical sensitivities. What we see in this profile, looking at 630 plus metabolites, is that all the illnesses we look at have a pattern which will help us to make those diagnoses.
Mm-hmm.
For example, the pattern that we found in chronic fatigue really changes the whole paradigm of chronic fatigue, meaning with 6 different measurements in men and 11 in women, you can separate people with chronic fatigue syndrome from patients who don't with an accuracy of 94 to 96%. Now,
Wow.
this is already published. This was a couple of years ago.
Yeah.
So what we're looking at is a method which will change the way medicine is practiced, ultimately, that instead of 400 blood tests, you'll get one. And with this blood test, you'll be able to, by pattern recognition, go, this fits into the pattern of mold or Lyme or this, or it's got some of these, so that we can metabolically begin to assign a diagnosis maybe sooner. In other words, you don't have to wait 12 years to get the diagnosis of Lyme. Someone can look at it and go, oh, that's a Lyme profile. I will assume that once this is available, the entire way we practice medicine will change.
I mean, it sounds like it, and from reading the papers, I mean, it would be so helpful to be able to start to, put people in different areas and start to know where to focus much more quickly, especially with that kind of accuracy. I mean, even as a lot of the listeners probably know, I mean, Lyme testing is pretty miserable,
Yeah.
It's
as good as we've got, and it's not that good.
Right. And so to be able to learn, and we keep talking about learning more and more and more about a patient and treating them as a whole. So if we can look at them as more of a whole and then sort of say, hey, we're looking at your whole, but you're more over here with chronic fatigue, but you're more here with Lyme, you're here with mold, you might be chronic fatigue from Lyme, whatever we learn. That sounds remarkable.
I believe that it will be a fabulous tool for us once it's commercially available. It's also going to point out other metabolic interventions that patients need, but what it's not going to do is tell us when to do those interventions.
Mm-hmm.
So one of the biggest problems that I see is everyone that I treat has mitochondrial dysfunction. It's partly part of the deal, which is when the body recognizes that it is either under attack from a toxin or from an infection, it intentionally shuts down mitochondrial function to help deal with that threat. So to tell patients that they have mitochondrial dysfunction is belaboring the obvious, forgive me. And what many people don't realize is the interventions that we would typically use for that, CoQ10, L-carnitine, L-taurine, D-ribose, malic acid, all of our favorite things that would help mitochondria to function better, won't do much, if anything, when the patient is still fighting the threat.
Right.
So it's not as simple as just seeing a number on a lab report. Your potassium is low. I'm giving you potassium. It's recognizing where is that being in their struggle, and do I have to do some things first before I can reboot those mitochondria? And we're going to have to change the entire way we think medically to think in terms of where is that person in the healing cycle? How compromised are we if we're going to really begin to do a better job?
And I totally agree. And I'm looking forward to that time, you know, because it's just like, we're not there, and people are suffering because we're not there. Somebody had a question about if we don't, and I think we can sort of dovetail it into what you're talking about, is it's around communication, right? Like, so how do we best communicate with our patients? And the specific question is, if you don't see them for a few months, what's the best way to bring you up to speed so that you don't spend it, you know, a whole appointment talking about the past? And so I'd like to maybe chat about that, but also just in general, how do we frame the conversation with our patients so that we can help them provide us with the appropriate information without just I mean, because I'm sure you sat in the appointment where it's just like we're talking about the same thing over and over, and we're getting deeper and deeper to the pain, and it's almost like, you know, therapy gone wild, and we want to help that person, but going down 45 minutes off in a tangent isn't always the best thing. And so I'm sure you've been there, and you have some tips and tricks that you can share with both me and all the listeners who are either doctors or patients or other providers, because the more efficient we are in our conversation, I think, while still being, you know, open and compassionate and hearing what's the real story. How do we get that real story versus the story, I guess, is the question.
You're doing to me what Scott does, which is to ask me 6 questions at the same time. But I'm going to do what I normally do, is I want to tease that apart.
You're going to deflect them all? No.
I'm going to tease it apart because you're asking good questions, and I want to be sure that listeners understand the answers to all of those pieces of it. So first of all, my shortest visit with a patient is 30 minutes.
Right.
You can't do this work with a 7 to 15 minute office visit. You're barely catching up at that point. Second, most of my patients have been trained to provide me with a written summary of what they have been doing as an update, which they give to me at the time that they come in to see me, and with a list of their immediate supplements, so I don't have to go over that in more detail. However, I do want to hear from them directly an update. So that's my starting point of how to move forward.
Right.
What you're referring to is a particular type of patient who is totally stuck in the past in what I call their story, meaning they are obsessed with telling you every detail of what happened, and they'll tell you the same story passionately every single office visit.
Yep.
They are stuck there. That is not a place to heal from. They are literally stuck in the past, and they literally feel almost obsessed with the need for you to understand what happened to them and how bad they feel. Now, I deal with this by, and it might seem rude, but it's not therapeutic. I deal with this by saying, I really, truly hear your story. It's not unique. I'm sorry. I get this story all day long, but I really do hear how much you've been suffering. But you can't tell me this story today. What I need to do is to talk with you about what we're going to do about it.
Yeah.
If you insist on not moving until you tell me the story, and you know, Tom, that there are people who you can't move forward until they think they've shared this one more time.
Yep.
What I attempt to teach them, and I don't mean this meanly, is you're stuck here. You're stuck in your story. This is not a place to heal from. We have got to move. So here's the deal. I'm not going to listen to you tell your story.
Right.
What I am going to listen to is what we're going to do about it. And I think that's what you're referring to here in terms of a need to, that's just as stuck a place for some of these folks as whether they're stuck structurally or whether they're stuck. Yeah. It's a very stuck psychological place from which no movement is possible until they get off that place.
Well, and you know, it's hard as a practitioner. I mean, because I want to hear their story, but I know I agree with everything you said. I mean, it's not therapeutic. And But the other thing is, when we try to reframe it, sometimes that conversation, if you're unwilling to say that up front, when you recognize it, like your example, then the practitioner can get frustrated. And then you get behind time and you're not helping them and you're not helping other people. And right before we came on, we were just talking a little bit about how I've just always been very impressed with the way you stand up and you state truth, but you state it in a loving and compassionate way, because the truth isn't always fun to hear.
Right.
But you say it in a way that's real, and you're not judging or yelling at them.
I don't. Because I can feel my frustration when I know they're stuck and they're still telling me that story. And anyone who practices this has been where we are. This is not a unique experience. Again, I've gotten more blunt and proactive the older I get. I don't have the time to waste their time and mine hearing a story that isn't going anywhere.
And you've heard 16 times already.
Right. So what I will tell them is, this is your stuck place.
Yeah.
You can't get well this. If you insist that this is where you want to stay, you need another physician, because I can't help you here. I can't. If you will listen to my words and understand the caring with which I say them, if you're willing to get off this place, the deal has to be, we're not going to tell this story again. If you can agree to that, I can work with you. If you can't, and assume that that makes me an incompassionate jerk who is simply not willing to hear, right. I've been accused of that. Then I can't help you, and you really would be better served having someone who you think is paying attention to you.
Yeah.
So, be honest, I've fired people like that when they have made it very clear that no, unless you hear me out every time, you are an inconsiderate, heartless lout. And I'm thinking, well, I don't think I am, but I don't think you can hear you. So we have no place to go with this.
And it's hard because, like you said, I mean, you've spent like your entire adult life dedicated to helping these people and figure out how to help them get better. And sometimes it's telling them as accurately and lovingly as you can what's actually going on.
Right. So again, to reframe the languaging, sometimes some people will listen to, you are so attached to your story that you can't move. Yeah. So are you willing to let go of that attachment? I mean, again, I'm just using different languaging for the same phenomena.
Well, and sometimes they have those folks leave for a while.
Right.
They come back or they don't. But a lot of times if people do come back, they're like, wow, that was like, they just go from doctor to doctor telling the doctor what to do and telling their story. And, we're here to listen. I mean, I'm sure your first visit's even more than 30 minutes. I mean, we spend lots of time with not only this person, but people like them. 2
hours.
So
people have plenty of time to tell me what's going on. And in fairness, the vast majority of people that I work with aren't attached to this story. They want me to know it, but they want to move on. Okay, but how do I get well?
Yeah.
It's a small subpopulation of people we're talking about here. And my heart goes out to them, but they're just so attached to their story that they can't move. And my message to practitioners is, let them go. You can't help them. You will not help them. In fact, you're enabling them.
Right.
By being willing to listen to this story and not moving them forward. You're now part of the problem, not the solution. So for those of you who are out there in practice, let them go. It's the kindest, most healthy thing you can do. And it'll keep you from going nuts having to hear that story one more time.
Yeah, and it's always interesting to me because I find that I have some people who start to behave that way, but as asked for more and more of here, your new patient visits, give me a 1 to 2 page written summary. On your follow-up, give me a written summary. They have a chance to express themselves and maybe highlight the key points, and then we can focus in. But so I've tried to actively not enable that in people who are close but not there yet, because there's so much suffering. It's so easy to go down that rabbit hole because we just want to get better. And then we get all these other responses, these body's protective responses, the limbic responses, the vagus, and they trap you there. So if we can help keep them from going there, and I think what you're saying, Neil, is we give people the opportunity to express their story in an appropriately therapeutic way, and in a way that helps us take action to get them better, not just sit there spinning our wheels in the mud.
Yeah, absolutely. All of our patients are suffering, and I would like to think that I treat all the people who come to see me as individuals. They do have a unique story. I'm certainly willing to listen to that story so that I can use the information to go, you've got this, this, and this. Let's go work on this and let's move forward.
Yeah.
Literally, those people who are in this stuck loop literally are telling us that they have a limbic vagal dysfunction. They're literally reinforcing that limbic dysfunction with every negative thought that they have. And this whole story is a negative thought. It's like a massive reinforcement of limbic dysfunction. And they don't understand that they're doing that to themselves.
And they're not doing it on purpose either, right? I mean,
no, I think they honestly feel that nobody really listens to them. And then that becomes their story. And you're going to prove to you that you don't listen either.
Well, I was recently talking to someone who specializes in post-betrayal syndrome, and like just an approach to after betrayal, kind of regaining sort of, yourself again and moving on beyond that. And we sat down to talk, and she's like, I don't know what you guys we're going to talk about. I don't see how your patients are betrayed. And I was like, really? I mean, to me, it's like accidentally or otherwise, our patients are betrayed by the medical system that they put so much trust in, and their primary care doctor, who's helped them for so many years, accidentally just kind of or otherwise betrays their trust. And because we're just so bought into the system of take this pill or do this test or have this surgery, then we're fixed.
Yeah, their bodies betray them.
Yeah,
that's a universal perception, which is, I thought my body liked me, and now it won't get well no matter what I'm doing. In fact, when I try to do stuff, it reacts badly. So whether that person is capable of understanding or not, our patients do feel betrayed by their bodies, by their lives, by their families.
Oh my God!
Yeah. Physicians that they've been working with pull their families apart and say, this has got to be in their head. There's nothing that causes all of these symptoms. And then the family, thinking that they're being helpful, goes, your doctor has shared with me that
there's nothing wrong with you.
So I can no longer support any perception that you're ill. And then they've been betrayed by everybody.
Yeah, absolutely. And somebody was commenting, Donna just mentioned, they may even need to see someone, a mental health professional, to kind of help with that too. And I think these things are all critical. A lot of people are like, well, should I see someone who's skilled in helping me deal with these emotional pieces? I'm like, well, yeah. And I find that a lot of people, though, are afraid, rightfully so in some cases, and feel betrayed too, because they got put on the antidepressant or, sort of the Valium, to kind of, and it's like, but that wasn't their cause, and people just put a label on them and give them a medicine, and then they don't look deeper. And so they don't always want to do that. And I find that some of these approaches, and sometimes it's even prescription medicines, not that much, but sometimes it's very stabilizing. Like in a suicidal patient with Bartonella, number one thing is not Bartonella. Truly actively suicidal.
Oh, I agree. Psychotropic medication has a definite place in these illnesses to stabilize until we can take care of the cause. So not for everybody. Some of my patients don't respond well to it,
Right,
but
right.
for some people it does. I mean, there's a definite role for mental health professionals in this realm, especially if they have training in PTSD, particularly along the lines that Dr. Stephen Porges outlines, where if you really understand the physiology of the vagus nerve and can treat it from a mental health perspective, then you can move forward. And this involves really basic things like structuring your office so that the colors of the wall are soothing, that it's not rushed around and busy. It's soothing. Your voice is soothing. The setting is open to them. The attitude not only you have, but of your entire staff, how they're treated, respect being paramount in that particular process, that alone sets the tone for this is a safe place. We can help you here. And in that way, what they are perceiving speaks louder than words.
Right. Well, and I think that one of the reasons osteopaths are so successful, at least osteopaths who do manual medicine are so successful, is they have a quiet, calm office. You lay down on something really comfortable, and they do something super unique, which is actually put their hands on you. And I want to say that the magic, if you will, of osteopathic treatment is that these are highly skilled practitioners who are making huge changes structurally and energetically, but a large component of that is also the safety that they create.
Right.
I mean,
I completely agree. I've often said that many patients who've come to see me, and this goes back many, many years, have been told all kinds of things verbally by all kinds of physicians, and they've learned to distrust that. But if I can get them on my table with my hands on them, my hands can communicate that I care at a deeper level than my words. And so I'm in 100% agreement with you here.
Yeah. And, another thing too that I found is we're taught that, or maybe again, accidentally taught or betrayed, who knows what happened in your particular scenario, but we're not supposed to feel bad emotions or feelings. And then when we do, we push them aside. And, I mentioned to you previously that, I ran into a gal by the name of Joan Rosenberg, who's a PhD psychologist, who wrote a book, 90 Seconds to Life You Love. And her whole thing is you start out by, you're going to have certain emotions. She names 8 of them. But when they come up, just experience them and just make a commitment to the next time one comes up, experience them, because you'll feel emotional. And within about 90 seconds or less, it'll chill out and you'll have these things happen. But the more that we're present with what's actually real in our body now, the easier it is to go. So it's kind of like Eckhart Tolle for like people who want like the manual of how to do it, and it's really interesting. So I'll throw that in the link, but I think it's being able to say that what's going on in my body is actually happening, defining what is actually like my story versus what is really happening, and feeling those emotions. And I think all those points you bring up, Neil, are so critical to healing. And the part that I love so much about a large part of what we've been talking about is these are things people can do at home, is to, instead of putting all that anger out on the system that didn't serve them well, is to find people like yourself who can help them, but then also to go back and say, look, I can actually help myself. I feel like our medical system just rips the personal power away from people. It's just so frustrating.
And that's part of the beauty of the Annie Hopper DNRS program, or some of the vagal exercises, or brain tap, which is you can do that yourself and regain And again, I agree with you, Tom, that many meditative practices include the possibility of allowing whatever you're feeling to arise, be experienced, and then leave, which is what it does. The problem for many people is that it arises, is perceived, and then we hang on to it. It's our attachment to those emotions, and as opposed to, no, I'm just going to notice that it's there. I'm going to let it bubble up of its own, let it do its thing, and then it can be gone. But unfortunately, I would submit to you that we should probably teach meditation to all children, because in the stress-filled world that they live in, that skill will do them a whole lot more good than studying calculus, say.
Right. Well, and one of the things that I found, and I even experienced this weekend, is that an emotion came up because of a sort of an emotionally charged sort of experience. And so the person next to me put their hand on my shoulder and said, breathe. Don't dare swallow it. Do not dare swallow it. Breathe. Just breathe. And it was crazy because I come from a background where, you get angry and you hold it in. And then eventually you blow up, usually when you're not around other people or at home, which is like the worst place. But, and as I've gotten older, I'm better at dealing with just the environment that I grew up in and dealing with my emotions. But a lot of what we do is stressful. Life, our work. And it was just so interesting. And it actually happened to be this Joan who wrote that book, because I happened to run into her at a conference, and I was like, literally, she could just, and it was like, if you just keep breathing as you're feeling that emotion. But it's really interesting. A lot of the things we do to help heal is breathing. And people, like if you do yoga, like we say, breathe into your pelvis. Well, why do we tell you to do that? Well, one of the reasons is if you take a full breath, you're going to detoxify better, because all of our detoxification in the thorax there, in the belly, this pressure changes from breathing. And, but our breath gets trapped. So it's an interesting thing, because there's so much healing that can go on. And then you can talk about the energetics and how it impacts like the vagal tone of the heart and all this. So breathing is such a free thing. It's like free. You can do it at home. So there are a couple other questions, and I think we should hit one, and then Scott gave us yet another one, which at the very beginning, which I think is a great wrap up to everything. Because I can't thank you enough. It's been like an hour. I mean, we could do this all day, I think. But there was a question about what's the best way to test your environment, and your home or the school or whatever. I think that's a really important one. And then we'll close with Scott's question.
It's a very good question, and unfortunately, people are not going to like my answer. We have some ways of testing our environment which are fairly good, but we don't have any perfect ways to check home, car, work environments. We just don't have those tools yet. There are several tools. The one that's used in the building industry is called air sampling, and it's the most inaccurate, which involves literally taking a sample of mold spores in the middle of the air in the room. Now, the reason that's inaccurate is because that's not where the mold spores are. Mold spores are heavier than air, so that if there were any, they're on the floor right now. They're not floating around in the air. So if you have that type of sampling, you can be told that this is a safe environment, and you can be absolutely wrong.
Right.
Now, that is the standard of the building industry, and it will come as no shock to many of your listeners that the reason for that is because it's so inaccurate. That means a contractor or a landlord can do that and tell the tenant or someone, I've measured it and you're fine. We have nothing to talk about. I'm going to move off from that. The other two methods are plate sampling, where you can get hold of a petri dish, which contains a media that grows mold, put it on the floor of the room, open the dish so that it can literally sample what's down there for 2 hours, put the plate top back on, and then just see what grows over 3 to 5 days. If a lot of mold is growing, you can get those plates analyzed to see whether or not those are toxic mold species or just ordinary non-toxic mold. So just because a lot is growing doesn't mean it's toxic.
Yep.
The third method is called ERMI testing. It's considered by many to be the best but still imperfect, where you vacuum up dust from a room and send the dust into a company that uses PCR technology to measure 36 different toxic mold species, and you can quantitate what's in that room. And people who do remediation can look at those mold species and go, okay, I think that might be in your HVAC system, or okay, I think that's behind a wall. And then you can work with an expert to see, am I being exposed and what do I do about it?
Awesome. Yeah, those are super good. So I wanted to roll back to Scott's question from the beginning, partly because it's sort of like what I was thinking of too. So, I mean, it's nice that we both think alike and ask really long questions that have 16 different questions embedded in them.
Having had dinner with both of you.
Yeah, at the same time, actually.
At the same time, I can attest to that.
But, kind of like, where do you see all this going? I mean, what are the potential game changers? I mean, maybe outside of the testing that from Dr. Navio, and, are there areas where there are sort of that we need to have better tools, I mean, outside of testing in detox or immune support or killing things? I mean, are there like one or two places where you see we could make big strides over the next 5 or 10 years?
Boy, I wish I could say yes. I'm not sure I can, because I think this is a multi-involved issue, so that we need to be able to have quicker, better tools to quiet the nervous system. We need to have perhaps more accurate measurements. Our current mold tests are a tremendous improvement on what we had 10 years ago, but they still don't measure all mold species, and we still need to be more comprehensive than we did.
Right.
We need better treatments. It takes me a year or more to get mold out of patients. I'm sure we can do better. I don't currently know how, because it has to be based on my perceived ability of that patient to handle what I'm giving them. So I'd love to do better, faster. We need that. We need to have better detoxification methods. We need to be able to help all of these systems come together to move this forward. So I'm not sure I see anything immediately on the horizon, except to find ways to do better than what we're currently doing right now.
Right. It's hard. I mean, we gotta, who knows when it's gonna show up, and I'm always waiting for it, but I think for me, it just goes back to kind of what you had said in the beginning. And it always happens that somebody tries to phone call you here. We have to go back to sitting down and taking a really good history and physical exam and hearing the story, the pertinent parts of that story, and really just doing that clinical piece. And I mean, I think that's the part that's always been, I've always heard from you is we look at people as an individual, we find out what the heck is wrong with them. We start with focusing on them first, and then the things that are going after them second, or at least at the same time, but always keeping them at the center of the whole thing.
The biggest change that might happen for our patients is if the medical field would embrace the concept of Lyme and mold, so that other doctors would put it way up on their lists, so that they would have a sensitization to, these symptoms that I'm getting are a clear demonstration of mold or Lyme. That's where I need to live, as opposed to, well, that makes no sense to me. You can't have all of those symptoms. So the number one thing that probably needs to change is the consciousness of medicine itself.
Awesome. I would totally agree. So with that, I want to say thanks, Neil. This is amazing that you're willing to take all this time to share with us. Again, everybody, I just threw in the comments the link to Dr. Nathan's book. So it'll be in there a couple times. It's Toxic: Heal Your Body from Mold Toxicity, Lyme Disease, Multiple Chronic Chemical Sensitivities, and Chronic Environmental Illness. It's a must read. I recommend all my patients go and check that out, particularly for the sensitive chronic patient. It's an incredible resource, so thank you. And for all you guys who stuck it out to hang out with us, I just wanted to say thanks. I have a couple of free gifts I like to give folks. If you head over to the website, the link is right there. And basically, it'll have some resources that can help with you get going with some of these vagus nerve exercises and other things like that, so that you'll be able to start doing some of these things at home. And then while you're waiting to get some of those resources that Dr. Nathan shared with us. So wanted to say thanks. I think there was another question or two that popped in there. I'll make sure we answer that in the comments. And again, Dr. Nathan, thanks so much for joining us today.
Thank you for having me, Tom. Always a pleasure.
Take care, everybody. Have a great day.
Okay, take care. Bye-bye. Be well.